Assalamu alaikum. My dear chairman, it is an honor to me to be part of this elegant and more scientific meeting. Our case is a 65-year-old male patient. He diagnosed as hypertension 5 years ago, and he put on lisinopril 20 milligram per day and hydrochlorothiazide 12.5 milligram per day. He taking this medication in the morning. He measured his blood pressure in nearby pharmacy several times, and he was told that the blood pressure reading was high. And for this purpose, amlodipine was added to his drug therapy, and 5 milligram per day was added in the morning by the patient himself, not on his doctor prescription. 1 week later, the patient started to complain of fatigue and dizziness, which is not related to puncture. He came to check his blood pressure in our clinic. He's a smoker, he is dyslipidemic, and taking atorvastatin 20 milligram per day at night time. His physical examination revealed that he's obese. His body mass index is 33.6. Apart from this, his whole examination is normal, apart from S4 here over the apex. Repeated blood pressure measurement in the office revealed that his blood pressure is uncontrolled. His systolic blood pressure is 150 over the systolic blood pressure is an average of 85. His standing blood pressure did not show any changes. We ordered to him a complete laboratory investigation, which reveals that a complete blood picture, fasting blood glucose, fasting lipid and renal function, serum uric acid, electrolyte, urine analysis, and liver function test, and thyroid function test is within normal. So, due to his confusing symptoms of dizziness and fatigue, we suspected in this patient may develop an hypotensive attacks. So ambulatory blood pressure, and to confirm the diagnosis of hypertension, we ordered to him ambulatory blood pressure. As we see here, ambulatory blood pressure sees that the 24-hour period is over 130 over 80, so it is elevated. The daytime period is also elevated. With nighttime period, it's over 120 over 70. So it is having our diagnosis was given to this patient with uncontrolled hypertension with nocturnal hypertension, or maybe he is riser. So taking in account this nocturnal hypertension, we started to investigate what is the causes of this nocturnal hypertension. The first, we have to rule out the most common cause of nocturnal hypertension with obstructive sleep apnea. And from investigation, we ruled out diabetes and kidney diseases. So we returned to the patient and his wife and asked for symptoms for obstructive sleep apnea. We asked her wife if he snored. She tell yes, he snored at night and he several times awake during night. And the patient reported symptom of morning headache and day sleepiness. So upon this symptom, we requested a polysomnographic study to confirm the diagnosis of obstructive sleep apnea. The study showed that the apnea-hypopnea index is 89.4, which means that the patient develop or have a severe obstructive sleep apnea. Chest consultation recommend starting treatment in the form of continuous positive airway pressure, which the patient was compliant to this treatment. So what is the next step for this patient? To add another antihypertensive medication, as his office blood pressure and the ambulatory blood pressure show increasing in blood pressure, or to treat all the secondary causes and reversible causes, and to advocate the patient to lifestyle modification in the form of weight reduction, decreased salt intake, exercise, stop smoking, and the treatment of obstructive sleep apnea, and recheck blood pressure. What to do? We choose the second choice. We start to reverse all the secondary cause or treatment of all the secondary causes for the patient. And we advise him to come back after 3 months. After 3 months of treatment of CPAP, the patient reported disappearance of headache, sleepiness, and he stopped smoking, and he lost 4 kilograms of his weight. Repeated clinic blood pressure measurement reveals that his systolic blood pressure is around 140, his diastolic blood pressure is around 85, and the ambulatory blood pressure show marked improvement. His 24-hour is optimum 130/70. The daytime is 134/75, and there is very decrease in the night time period. It is 120/60. So we recommend or advise this patient for periodic blood pressure evaluation at home, lifestyle modification in the form of weight reduction, decreased salt intake, exercise, and stop smoking, treatment of obstructive sleep apnea, and we continue on the same antihypertensive medication without increasing any doses or increasing or adding any antihypertensive treatment. Our take-home message from this case: the role of ambulatory blood pressure monitoring in this case is to confirm a diagnosis of uncontrolled hypertension, to exclude white coat hypertension, diagnosis of nocturnal hypertension and non-dipping state, and as a previous colleague said, which is a very important prognostic factor and a risk for cardiovascular event, and to evaluate the degree of blood pressure control. Obstructive sleep apnea affect 4 to 6% of the general middle-age population with increasing age. Recent studies have shown that obstructive sleep apnea contribute to poor blood pressure control, and more than 70% of resistant hypertension patients have obstructive sleep apnea. CPAP is the gold standard treatment for obstructive sleep apnea, and several studies showed marked variability in the effect of blood pressure control by the CPAP, إنه هو بيدبند على beneficial effect of CPAP compliance. البيشنت لازم يمشي at least 4 hours per night عشان develop good achievement of blood pressure control. Okay. Okay. في سيرفي الاول ان انا بشوف قد ايه البيشنت ده عنده obstructive sleep apnea. الموست كومن سيرفي اللي هو ستوب بانج، ان انا ببتدي اسال العيان على السيمبتومز اوف سليب ابنيا، زي ان هو عنده سنورنج، سليبنس بالليل، هيدك الصبح. وفي بعض البارامتر بتبقى اكتر، لو البادي ماس اندكس بتاعته اكتر من 35، النيك سيركمفرنس اكتر من 40. شورت نيك النيك بتاعته. فلو كل الكرايتيريا دي السبجكتيف الاوبجكتيف وصلتني ان انا اعمل اوبستراكتيف سليب ابني، السيرفي ده وصلني ابتدي اطلب له بوليسيلمونر. يعني لو يعني قصدي حضرتك لو ما فيش الحاجه دي we should not rule out obstructive sleep apnea or should، او في نسبه برضو من الناس ممكن يكون عندهم من غير ما عندهم الكرايتيريا دي. السيرفي ده 85 لو انا كملت من 5 ل 8 بوينتس لا ده 100% ان ده عنده سليب ابنيا. لو اقل من كده لا هيبقى mild or moderate sleep apnea، اللي هو التريتمنت بتاعتي مش هيبقى سي باب، فلا مش هيبقى. اوكي. طب وات اباوت انا عارف ان السي باب ماسك بيبقى فيري انوينج، الكومبلاينس بتاعه للعيانين دول بيبقوا كومبلاينت بيحطوه ديلي ولا الدنيا بيبقى شكلها ايه؟ لا هو بيبقى during night، وهو ده الفرق في التريتمنت بتاعي، هو بيجيب افكت على البلاد بريشر كنترول ولا لا. هو عشان تو اتشيف جود بلاد بريشر كنترول لازم العيان اتليست يحطوا 4 ساعات per night، وهو ده اللي خلى الاستادي.
هي دي المشكله يا دكتور هبه، هي دي المشكله اللي بتبقى بتواجهنا، ان العيان اصلا السباب بيخليه يبقى اغلبه ما بيركبش
مش طايق نفسه.
لا في الاول بس يعني يوجوالي ده من اكسبيرينس مع ناس ومنهم ناس قرايبي، لا بعد كده بيعتبر ان ده جزء من حياته وما بيقدرش يستغنى عنه. في ناس كتيره بعد كده بتحس بفرق كبير في حياتها كلها يعني.
خصوصا طبعا مع حضرتك، خصوصا في الناس اللي بيبقى عندهم سنورنج وبيبقى عندهم انتربشن اوف سليب بسبب الحكايه دي بيفرق معاهم، بس لو ما عندهمش السيفير سيمبتومز دول يمكن يبقى فيري انوينج بالنسبه لهم،
بالذات الداي تايم سولمنس اللي بيبقى صاحي مدروخ ومش قادر البتاع ده بيحس بفرق.
طيب وهو بيتحط
خلى ان الاستادي الايفكت بتاع السي باب مش يونيفرسال، ان هو بيجيب افكت في الكنترول بلاد بريشر. العيانين الكومبلاينت وبيبقى انديكيتد فيهم بيكنترول البلاد بريشر، انما العيانين اللي ما بيبقوش كومبلاينت عليه ما بيجيبش.
وحضرتك قلتي بيتحط 4 ساعات، ده المينيمم ولا ده هو المينيمم؟ طب الوقت ده بيتحدد حسب السيفيريتي اوف سيمبتومز ولا؟
يا جماعه فور ذا سيك اوف تايم بس في ورك شوب هناك فضروري نخلص.
وعلى قدره العيان ان هو يستحمل، لو ات نايت اتليست يعني هيحطوا 6 ل 8 ساعات.
اوكي شكرا جدا يا دكتور هبه.
اوكي شكرا دكتور هبه. We conclude this session. Thank you very much for all of you. Thank you.